Okay, we're going to go ahead and get started for our panel discussion on using implementation strategies. And we have two case presentations for you. The first case presentation will be by Christie Bartels and Edmond Ramley. Christie Bartels is an associate professor in rheumatology in the Department of Medicine, and we'll be talking about BP Connect, implementation strategies to connect cardiovascular disease prevention in specialty clinics. And Edmond Ramley is an assistant professor in the Department of Family Medicine and Community Health. And again, this is a wonderful example of a collaboration between engineering, systems engineers, and clinical investigators. So our second panel will be using the ERIC taxonomy to develop a bundled implementation strategy featuring Andrew Quanbeck from our D&I Launchpad and assistant professor in the Department of Family Medicine and Community Health, and Randall Brown, associate professor in Family Medicine and Community Health. So we'll start with Christie and Edmond.
All right, thank you very much, Jane. I'm gonna go ahead and share my screen.
And fantastic. And while you're getting that loaded, I'll just say that I'm Christie Bartels. I'm a rheumatologist and health services researcher. And just to get us started this morning, I'll go ahead and advance to the next slide, Edmond. Again, I really enjoyed participating in this conference, and I'm glad that Jane called out this opportunity to collaborate with our engineering colleagues. The question I had as a clinician, as a rheumatologist, was that the patients I was taking care of with diseases like rheumatoid arthritis and lupus were dying about 5 to 10 years before peers, and it was actually not from their RA or lupus. It was in fact from cardiovascular disease. So one of the things that I originally hit on was that basically 90% of those specialty visits where our patients were getting the bulk of their care actually failed to address the most common modifiable risk factor for cardiovascular disease, which is high blood pressure. So we adapted the literature from primary care to see what we could do in specialty clinics to check, advise, and connect patients back to high blood pressure care. So the protocol that we were using as an intervention was saying that we would check, we'd remeasure if they measured high. We'd advise the patient on why their rheumatic disease was linked to cardiovascular disease risk, and then we would connect them back to primary care within a month if it was confirmed high, which was consistent with AHA guidelines. Our research question was whether we could improve timely primary care follow-up after high blood pressures, and we had this nested question of whether this might actually improve blood pressure control across our population as well, though we weren't sure we'd be fully powered to see that.
So the intervention then is to having those check, advise, and connect behaviors be embedded in the routine workflows. And wearing my human factors and systems engineering hat, I understand the importance of looking at people who are conducting work as embedded in a system that includes multiple factors. So we used a blended conceptual framework, bringing together the Paris framework from implementation science, with the different components of intervention, implementation, context, and recipient, with a human factors engineering framework, the SEEPS framework, the Systems Engineering Initiative for Patient Safety, that was developed here at the University of Wisconsin, which emphasizes the interrelations between work system elements of organization, environment, tools and technology, and tasks with the people conducting the work at the center, and how that drives processes, in our case here, remeasurement and timely follow-up, as well as outcomes, like a change in BP. And so the implementation strategies that we used to bring that together were 4 core strategies: to engage staff in co-designing the protocol and tailoring it to their needs, as well as co-designing the implementation bundle with focus groups before the intervention, and at month 3 to do some formative evaluation and responsiveness. Educating them on, reminding them on the BP technique with a didactic session, as well as the importance of hypertension and cardiovascular disease risk for patients with rheumatic conditions, and practicing talking points in a role play fashion, as well as practicing the new workflow that we introduced to the EHR in a playground environment. And the 3 things that we did in the EHR to support staff with electronic health record reminders were to cue them to remeasure high blood pressures, cue them to provide brief advice to patients, supported by a patient brochure that we co-designed with them, and then an order set to order scheduling of primary care appointment within 4 weeks that they would get assistance on with the scheduler before they leave the clinic that day. Finally, we evaluated and iterated on a monthly basis to provide audit and feedback to staff in person at first, and then after month 6 by email. So Dr. Powell talked about the concept mapping of the ERIC strategies with Thomas Waltz and Laura Damschroder's paper on concept mapping. So it turns out that when you look at that paper, they actually categorized these strategies by importance and feasibility. So if you move all the way to the right, that those were strategies that were deemed more important, and all the way to the top, those were strategies that were deemed more feasible. And in the paper, they talked about that as a go zone. So it turns out that across those 4 implementation core components that I described, we did use 27 discrete strategies from that go zone, as well as other ones not from the go zone. But here are the ones from the go zone, and you can see how they cluster across those 4 core components of engaging, educating, providing support, and evaluating to iterate. So I'm going to go over some examples. The first one that I'll go over is supporting staff with electronic health record reminders. So starting all the way at the bottom left, you can see that there are a number of relevant ERIC strategies that are represented here. In the Waltz category of supporting clinicians, we have facilitating relay of data to staff as well as reminding them. And then in the change infrastructure category, we're changing the electronic health record system. So essentially what we did is, you can see the top left, that's the first best practice alert that comes up when a staff member puts in a high blood pressure, higher than 140/90, and then it reminds them to remeasure. Then the second one pops up if the remeasurement was high, and that allows them to go into an order set, a smart set on the right, that walks them through talking points to offer follow-up assistance to the follow-up scheduling assistance to the patients. And the smart set is actually smart enough, the way we designed it, to know if the blood pressure is so high that it requires an appointment with a prescribing provider, or that it could be an appointment with a nurse in primary care. So the next example is our audit and feedback strategy. Again, top right, you can see the relevant ERIC strategies, not only the audit and feedback itself, but making the training dynamic. And this strategies that we developed included both audit and feedback, as well as a barrier assessment and action planning on a monthly basis. So we developed a guided audit and feedback tool that is available to download online at the link here. And we also have a paper in review providing in detail the reporting of the different components of the audit and feedback strategy and how they build on theory, which was a point that Dr. Damschroder made earlier this morning. And so you can see we give staff the opportunity to really guide the conversation. Do they want to start with talking about their data? Do they want to start with talking about barriers and action planning? And then providing them their data on each of the target behaviors, like remeasuring the BP and offering the BP follow-up, and how they've been doing over time, as well as how they've been doing compared with the aggregate of their colleagues. So Christie will now talk about the outcomes of our strategies and intervention.
Fantastic. So as you'll recall, our primary endpoint was looking at whether we could improve timely follow-up, which was defined as in less than 4 weeks. And what we see is that within the original time frame of the 6-month intervention, where we were doing face-to-face audit feedback monthly with staff, you see that we doubled the rate of timely follow-up for patients. You can also see that below that, we looked at sustainment, and out to 18 months, we saw an even greater impact there, that we maintained and improved our outcomes at 18 months. And I can proudly report that this has actually been in the clinic now for nearly 5 years at these 3 clinics, and it's disseminated to other clinics. But the other great thing that came up in yesterday's conversation and was mentioned again today as well is that we not only improved care for everyone, but we also got benefit. We showed a disparities reduction, that patients of Black race, for instance, benefited even more than everyone else. And again, I think this highlights the selling point that you can use implementation science to improve disparities and population health. And speaking of population health, the fantastic thing was that we also were curious whether we would actually impact population level blood pressures. And what I can proudly report here is that across 28,000 pre-visits and 28,000 post-visits, we saw a 9% reduction in rates of high blood pressure with that first measurement. Again, an apples to apples comparison, showing that we had an improved rate of population level of blood pressure control, and this was sustained and improved over time. If you're curious to learn more, you can look at our website at connecthealth.wis.edu. We have toolkits for Blood Pressure Connect or this BP Connect. But the other nice thing that we can report here is that using that same check, advise, connect model, and then also using the same 4 core implementation strategies, we were also able to implement this across a tobacco cessation protocol and using the same tools. And again, you can check out some videos and some toolkits at this website, which also has our audit feedback information if you're interested in that. With that, I'd like to thank my collaborators and our funders, and we will take questions after the next presentation. Thank you so much.
Thank you, Christie and Edmond. Fantastic work. And we'll turn now to hearing from Andrew and Randall with their presentation.
Great, thank you. And congratulations, Christie and Edmond. That is awesome work, and the population impact is really impressive. Well done. So I'm thrilled to be presenting today with my friend and colleague, Dr. Randall Brown. Randy's a family medicine physician, departmental colleague. He has an expertise in addiction medicine. He's the director of the university's Addiction Medicine Fellowship Program and has really been a pioneer in helping to establish addiction as a chronic medical disease. And largely due to his efforts, addiction is increasingly being treated in the primary healthcare system here in Wisconsin. So his work has really been an inspiration to me, and it's the kind of work that I really want to get behind as an implementation scientist, because I just think it's so important and there's so much potential impact in closing treatment gaps around substance use. Next slide, please. So I'll just quickly flash some acknowledgements and declarations. We're going to tell you briefly about a research trajectory that Randy and I have been working on together since around 2014. It's all been funded by the National Institute on Drug Abuse through an R34 and a subsequent R01 implementation research grants. Next slide. So the topic that we're going to focus on is opioid prescribing in primary care settings. If you've been paying attention to the media at all, you've no doubt heard about the problem of opioids. So I'm not going to spend a lot of time talking about that. You can read more about our work in this paper, which I did link to in the chat earlier, which describes kind of the problems of opioid prescribing and our study design that we're using to address this issue. Next slide. So we're here to talk primarily about the implementation strategies that we're using for this work. Why did we choose the strategies that we're using to address opioid prescribing in primary care? And so, as I've mentioned a few times, I'm a systems engineer, and I often go back to the model for improvement from the Institute for Healthcare Improvement. The first question, it's a really good fundamental question that I suggest everyone apply to their work, and it's deceptively simple but important. It's, what are we trying to accomplish? In our case, we're trying to reduce the risk of opioid overdose and potential misuse by instituting a set of universal precautions designed to mitigate risk. These recommendations have been around in the form of clinical guidelines since around 2009, and they were more recently formalized and codified by the CDC in clinical guidelines for opioid prescribing that were released in 2016. We received an R34 clinical trial planning grant to pilot test some implementation strategies related to this problem that I'm going to let Randy tell you a little bit about. Next slide. And Randy, you can take it over for the next couple of slides here.
Okay. Great, thanks, Andy, and thanks for the kind introduction. I barely know enough implementation science myself to even be dangerous. I think I'm more here speaking sort of in my role with this particular project where rubber met road around engaging clinics and some of the interesting things that we learned in the context of an implementation project around making that work well and being nimble to adapting to their needs as well as to the institutional environment in which we were trying to conduct this work. And one of the first things, I think we realized coming in, and it did play out, was it was important to get buy-in from higher level leadership in the context of preparing to do this work. And that came at the level of the overall UW health system, and then medical directors of clinics to get support for the work. But then from there, those were individuals that we didn't want to burden, and it was appropriate for them to be stepping back once we'd identified champions and change teams within the individual clinics that were participating. The other thing that we needed to adapt to as this project was launching was institutional policies and guidelines around opioid prescribing and monitoring practices were really getting up and running. And so that was something that we really needed to have an eye to and be sure that the interventions we were talking to clinics about and implementing lined up with those expectations for their practices. We had to do a little bit of adapting as well in terms of the design for the implementation and these interactions with clinics that took place over a course of 6 months, where we had initially conceived of fairly extended periods of interaction with the clinic early on to the tune of a half day, where we could get the clearest sense of workflows and take things from there. It became clear pretty early that trying to fit that into busy clinical schedules and offset costs of missed patient care sessions was going to be impractical. And so we adapted to hour-long meetings and email contact in between, sort of keep tabs on what the clinic was doing in terms of the aspects of opioid prescribing and monitoring they were choosing to address, how that was going, and what challenges were arising. We also found it helpful to tackle these sessions over the course of an early morning hour or lunch hour where we could provide food as well as a motivator. And we also provided continuing education credit in the context of these sessions. While we thought it was going to be really important for prescribers to be an active part of the entire process, it turned out at a couple of sites that wasn't necessarily the case. It was important to have them involved at some level, but we were really impressed to see the kinds of leadership and passion being taken over by other team members, including medical assistants and laboratory staff, depending on the particular issues around opioid prescribing and monitoring that their clinics were choosing to tackle. Another challenge that came up was this, again, was an implementation project at the level of clinics. And we were trying to maintain focus on that and an eye to how that intervention was changing prescribing patterns. And we found, and we anticipated to some extent, more thirst for addressing particular patients with particular challenges. And so that required some discussion and redirection on occasion. One thing we did to adapt to that and to try to address those needs in a way that was helpful to them, just by way of one example, was as the issue of benzodiazepine and opioid co-prescribing came up, the team came away from that session and conducted literature review around that topic and brought back a summative document that we think clinics found helpful by way of approaching that particular clinical area. So I'll turn it back to you with that, Andy.
Sure, and maybe just go back quickly to the prior slide, if you don't mind. So we took the learnings from our R34, and that was really valuable for us to really get clear on what we wanted to do for our strategies and the R01 that we're currently running. So we turned it in, you know, we then kind of went back and took all of our learnings and applied the ERIC framework. So we start with educational meetings coupled with audit and feedback as sort of our first system level strategy, which is our first intervention delivered. We then randomly assign clinics to either receive practice facilitation or not, where they're really a clinic and workflow kind of focused implementation strategy. And then finally, our last kind of phase of implementation is physician peer coaching, which is sort of a new, it's not part of ERIC, at least not exactly, although it could be potentially probably described as a series of different ERIC components. But really, we think that when it gets to the very difficult cases of patients on high dose or opioids or with co-prescribing of opioids and benzodiazepines, that it's going to take some pretty intensive kind of support from experienced physicians like Randy, kind of working with clinicians out in the community. Next slide. So I mentioned this one before. In terms of standardization, tracking, and reporting, we borrowed an approach that I first saw presented by a colleague named Brian Garner from RTI International. That was published in Implementation Science in 2018. Next slide. So I pulled out a table from Brian's paper, which shows kind of a cross-referencing of discrete strategies from the ERIC taxonomy on the in the columns, and then it's cross-listed with the implementation strategy specification guidance that was issued by Enola Proctor and Byron and others in 2013. So it basically goes back to that, you know, for every discrete strategy that ERIC specifies or lays out, you can specify it in terms of actors, actions, targets, and so forth. So, you know, to look at just how this is done in general terms, figure out what you're going to do, pick your ERIC strategy, lay out all of the components of specification. If you want to go to the next slide, I'll just give a quick example of how we're doing this for educational meetings. So, you know, we lay out specific activities. We lay out who's going to be delivering educational meetings, who we're asking to attend, when these things are happening, how long they're going to be happening, and then we take attendance at meetings to get a sense of the dose received, which gives us a good measure of fidelity to our proposed intervention or implementation strategy. So we've done this for all of the strategies that we're using, and obviously in a short presentation I won't go into all the details, but that's just an overview of how it can be done. We found it to work really. It's applied very nicely and is guiding a lot of our work in this project. Next slide. Okay, so that's it, and we'll move into the discussion portion. I just wanted to flash our websites up there for Randy's program and our lab. But I'll turn it back to Jane, I think.
That's right. So thank you, Andrew and Randy. That was fantastic. It's going to be really interesting to hear the results of that. I'd like to now introduce our discussants. Will be Laura and Byron. And of course, we want the rest of the panel to contribute as well. I'd like to first see if Laura and Byron have any questions for the panelists.
I think one question I would have, and Really great, Christie and Ed, to see the reduction in health disparities in your project. And this is a bit of a broad question, but I'm curious, what you attribute that to with respect to the intervention itself, and is there anything about the implementation process that you would link to those reductions?
I think that's a great question. I think one of the pieces here, it would be the fact that, for instance, patients with lupus have disproportionate, about 3-to-1 propensity in patients of color, and yet patients with lupus get a preponderance of their care in specialty clinics and not in primary care. So all these visits, what we actually, Edmond and I have done a lot of stakeholder research also, but when we talked with these women, what they were telling us before was that when we were measuring pressures and not giving them feedback, they were assuming their pressure was normal. So it's actually worse than not measuring, which is sort of interesting. So I think we actually had been giving them false signal, and suddenly now we were giving them real-time feedback. And it was actually similar to the theory that we were, the theories that we were using for the staff audit feedback. It's sort of interesting that we're probably applying also behaviorally to the patients, that when we were giving them a consistent signal. The other piece is patients who were already on prescribed therapy, but perhaps had gaps in adherence, were getting consistent feedback too. So the fact that we were not prescribing, but we were still seeing persistent improvement may have been improvement in adherence, might have been an improvement to just get patients back to primary care where they could see a prescriber, and might have just been increasing their awareness for behavioral factors as well. Edmond, I don't know if you have any other thoughts.
Yeah, just the importance of the consistent feedback. In Christie's prior research, she found that I think it was only 1 in 10 patients got recommended follow-up, and yeah, even when blood pressure was high, and many patients weren't even told whether their blood pressure was high or what the number was. And so, like Christie said, they assumed it was normal. And so the consistent feedback that every single time we measure, we let them know if it's high and we recommend follow-up, that it's embedded in the system, probably levels the playing field in terms of disparities.
Thank you.
Yeah, I have a question, I think for both of the pairs of presenters, and that is that you both talk about user and stakeholder input and kind of the refinements and adaptations that you made based on your input. And I'm wondering if you could just give us a high level feel for, did you build that in, or how did you build that in formally? So Christie, you mentioned, having patient interviews, or whether it was with providers. It may seem really obvious now looking back that blood pressure measured, nothing said. People assume that it's good, but wow, you had to actually ask about that. And was that built in? And then Andrew, and in your study, and Randy, you talked about participatory, or I think that was the word you used, feedback. And so I'm curious about, what you built in that made it participatory.
Thanks, great. So you asked the question a little bit about the stakeholder engagement, and interestingly, I can tell you this is sort of one of those, I started a K award actually looking at trying to change provider behavior, and I interviewed providers and patients, and you'll notice that my intervention ultimately was on staff, people like medical assistants. So you'll notice that actually this is an example of where a failed research project, initially when I was talking with rheumatologists, and they were saying, blood pressure isn't really in my wheelhouse, and so we needed to adapt and find a different approach. But interestingly, the patients, and then when we talk with primary care providers, they told us the answer. Primary care said, send them back. And patients said, we didn't even know. And so we were able to really take action on that aspect. So I think that's sort of the lesson learned. And again, we were engaging at different steps. So that was part of the K award. And then within the research program for the project we mentioned, again, I do think that engagement was our first component of our core element, and that was the tailoring a session that we did with the clinic staff. But I do think we learn every time we do that. I mean, things like the talking points that are nested in that order set were a direct example of that the end users, the medical assistants, told us what they would need to pull this off, and it was that they needed a script, and that would also help with things like turnover in the clinic, so that someone who was new to the clinic or afloat could execute this just as well as someone who had been formally trained. So those are just a couple of quick examples. Edmond, do you want to speak to that participatory piece, because that may have been from our audit feedback also?
Yes, so that's exactly what I was going to add. Is the other piece that's built in is at a different time scale. So the focus groups are at month 0 and month 3 to tailor and then refine. And then monthly, we're having these individual conversations with with staff in the audit and feedback, and typically those took 7 minutes on average. And in addition to talking about the data, we were talking about what barriers are you encountering. Here are some strategies that some of your colleagues have successfully used. What strategies do you commit to trying for the next month? And what are your goals on each of these target behaviors for next month? So that allowed us sort of, we have the big loop of the adaptation and then the smaller loops within.
That's awesome. 7 minutes, huh?
That's about how long it took. So initially, Christie was delivering the audit and feedback, and then as we scaled to other clinics, we've started outsourcing that to other people, and it's been successful so far. We've even experimented with phone-based audit and feedback during that initial 6 months, as well as a group versus individual.
Yeah, I mean, I just want to highlight, great example of kind of sustaining or at least continuing optimization of an initial implementation within very busy, challenging clinical settings. So Christie, you mentioned turnover, and you both talked about, kind of role transference, who has ownership of the problem and trying to find who that is and match our strategies and our targets accordingly. Andrew, I'm sure you've got stories as well.
Yeah, I mean, if I think all the way back to how this whole kind of line of research got started, I came from a background in systems engineering where we were doing a lot of quality improvement work in the addiction treatment field, and had developed a model that I had kind of shown briefly, this model for improvement that eventually got used by about 4,000 addiction treatment clinics, which represented, pretty sizable portion of the entire kind of specialty addiction treatment field. And when I got my PhD, I wanted to turn attention and say, can we do something about opioid prescribing with this approach? And got advice from program officers at NIDA that we should look at an R34 clinical trial planning grant. So to kind of formally build in a pilot testing phase, which really would allow us to very dig deeply before trying to scale this approach up. And so we were successful, and took our project officer's advice, got that project funded successfully. Between the original submission and the resubmission, a very important improvement to our study design was made, because we didn't originally have qualitative methods, and the original review said we might want to consider doing that. And that was a great suggestion, because I think that's how we learned so much that ended up really informing the approach that we're using now. And the study that we're doing now involves, I think, 34 clinics across the state. So we learned a lot through kind of a little bit of trial and error, and seeing what worked, what didn't, asking questions of our original participants and stakeholders, and we learned a lot that hopefully is leading to a more refined approach. Randy, any other thoughts or comments on that?
I mean, I guess so far as, the engagement piece on the ground, I mean, I think I alluded to some of this, but really, listening to what the providers on the ground had to say and doing whatever we could to adapt the intervention to their needs and the needs of the system. I made mention of, guidelines coming out, and there was a lot of tension around that. And so, answering to the provider's call for, can you help us out with this? I think was really helpful. And I made mention of, as they approached us with specific concerns about patients, trying to be creative about addressing that in a clinic level intervention without starting to get into individual patient consultation. And it was a fascinating process kind of all the way along. And I think anytime, we listened and heard and got creative about adapting, in the context of that R34, it was helpful in thinking about sort of this larger study and what interventions might look like as they get to the more granular levels.
Mhm.
I do have a question for Christie and Edmond regarding your consideration of primary care providers as stakeholders. Because ultimately, to reduce blood pressure, to have that level of impact, they did have a change in behavior. And I'm wondering if you could talk through, did you conceptualize that, or did that just happen to be a fortunate outcome?
So the primary care providers were actually part of my original K Award aim. And so the great thing was I had spoken with them early on. And interestingly, when we spoke with them, they were telling me repeated stories of where they were getting dinged because the patient's last blood pressure at, say, ophthalmology was off the charts, but no one told them. So interestingly, we could link it to their own, they were willing to take these patients back in their practice because then they had an opportunity to improve things that might actually impact like their paper performance and their overall performance metrics. And so it was great that we spoke with them early. They were on board with this. And then we continue to iterate that. And actually in each center that we go into, we make sure that we are connecting with primary care, that we're not overloading the system, and that we're making sure, again, that we can use the nursing resources when that's appropriate, and then the provider resources when it's appropriate. And that's part of one of the studies we're doing right now, is actually just looking more carefully at that primary care burden and making sure that we're partnering effectively with them too. Great question, Jane.
And that was a question in Menti as well. Were there barriers in connecting to the providers?
So our goal was to get it within 4 weeks. And what I can tell you is actually the median time fell from around 72 days to around 37 days. So we didn't exactly hit the 28-day mark, but we cut it in half, right? So the time to, so I'll tell you that it wasn't always possible to get it immediately in that time window, just because of constraints, of scheduling constraints. I do think some clinics have been really innovative. So we've got some clinics that have nursing visits, they have registered pharmacists who can handle these visits. And so that's the other aspect that we're looking at, is basically how can we use the full team to, again, accommodate that as well.
And I think I took a look at that question in Menti. I think they were asking about external providers, external PCPs. And so in our implementation so far, those patients got a follow-up order in their after visit summary and no scheduler assistance. But in the current project that's actually funded by ICTR DNI, we're collaborating with GHC, which is a local health plan, to assess whether those patients did follow up with an outside PCP, and to explore the feasibility of they put together a hotline, exactly, that UW schedulers could call patients with the PCP outside UW, but within GHC.
Great. I'd like to ask both pairs of panelists to see if you have any questions for Byron and Laura.
I guess I'm happy to kick it off. So scale up is a lot of what we think about right now, because we've already gone from UW only to another community setting in Wisconsin. So another health system, not an academic system, and we've even implemented the Grid Connect version of this in Atlanta. And what we've been learning is that a lot of what we have been doing, it benefits from having lots of expertise at the table and lots of research funding. And as we start scaling up toward operational embedding and toward things being routinely embedded, even as implementation strategies, so that we go from implementation that's very active from a research team to dissemination that local operational teams could implement locally. What thoughts do you have on best practices for scaling up those strategies, the way we design them, the way we package them, and the way we disseminate them?
That's clearly an easy question to answer, Ed. So thanks for throwing that at us.
Thanks, Byron. I'm glad you got this.
No, I think, I mean, I have a couple of thoughts, and I'm really glad that Laura's going to answer this question after I fumble this. But the one thought that I think is important for everyone to think about, and this is sort of emphasizing what I was saying about recreating the problem that we have with evidence-based interventions with implementation strategies, is obviously thinking about sustainment and scale up from the beginning. And so we talked a little bit about in our breakout session yesterday, this even for instance, our approaches to measuring fidelity. We might think of the gold standard approaches that involve sort of recordings of sessions and coding fidelity, but how are we actually going to, scale that up? And so sometimes I think we need to start with, even if it's not the optimal approach, what is actually going to be feasible for scaling something up. And so that's one thing that I would note. The other thing that I would note is that we love our theories, models, and frameworks in implementation science. There are a body of models and frameworks that are specific to scale up that might be helpful to take a look at. And I think that the extent to which things like sustainment and scale up require the same implementation strategies versus different implementation strategies is one that is still yet to be determined. So I've been involved with some work where we sort of conceptually try to look at different factors. So there's a paper led by Jennifer Lehman in implementation science where we look at different types of implementation strategies in that respect. I tend to think that there's not sort of I tend to think that there's a lot of overlap between these different types of strategies, and that they're not entirely conceptually distinct buckets. But I think the extent to which we need unique strategies for scaling up and need to develop the evidence for that is I think is a real frontier for the field. So I'm not sure we have a lot of answers on that yet.
Yeah, and for sure. I mean, and to add to that, I guess I take a step back from the problem of scale up and ask the question of what is the return on investment and to whom? What is the value proposition for this? And the second thing is that I don't think we pay nearly enough attention to, in the CFR, we call it design, quality, and packaging, but it's basically packaging in a way that is appealing, that is approachable, that's usable, all of those kind of user-centered criteria. And I think this is where, maybe a phase and where it's especially important to use user-centered design approaches or design thinking approaches to figure out what, how to package this so that it's appealing and usable. And then lastly, which it kind of goes to this, ROI question, is identifying and being explicit about identifying outcomes or benefits for all the different stakeholders. So, whether it's everyone from medical assistants, hey, here's an opportunity that you get to do some, have a real impact. Physicians, here's an opportunity to, delegate work to another person on your team, let alone to health systems. Here's, the investment, small, hopefully, and here's the payoff, big, quick, hopefully. That's the ideal, but even if it isn't, building the case for that, and really, finding those receiver points, because those receivers may be different depending on the context, depending on the system. So is it C-suite, decision makers? Is it individual primary care, clinical leaders? Is it even nursing, who knows what that is, but those entree points, those champions may vary from place to place.
That's
I
great.
agree, and finding the motivation is understanding the motivation, whether it's a pain point or, what's what motivation to the organization to take it on. And I also agree that identifying what is the smallest, most efficient implementation package, whether does it involve technical assistance that you need to provide, or can it all be provided in a toolkit? So a lot of questions there. So did one of our panelists have a question or comment?
Randy, I'm wondering if you want to take this opportunity for a free consult from Byron and Laura, as we're looking to. I want Randy to talk about this because he's really led this effort. But we're also doing a study in the trauma center at UW Hospital, and we're looking to, maybe it's not scale up as much as scale out what we've done in our primary care work to a new setting. Randy, maybe you can tell Byron and Laura a little bit about the STOMP project and our next steps, and see if they have any thoughts.
Oh yeah, that'd be great. So STOMP is our screening and trauma for opioid misuse prevention study. Just got out primary outcomes paper to Journal of Trauma and Acute Care Surgery, where the gist of the thing was we recruited 295 patients from trauma and orthopedic surgical units and followed them forward for 6 months, looking at primary outcomes around opioid misuse or the development of an actual use disorder. And we collected a fair slate of things by way of potential predictors and coned that down based on literature review as well as analytic considerations to 4 items in a potential screen. Also, we're going to be taking more of a look at sort of clinical factors, because really the things that panned out were more kind of mental health and anxiety related, where I have some thoughts that trauma surgeons might not be as interested in those factors as maybe clinical and injury related factors. So there's that, getting buy-in from that population. And then the next step that we're considering is implementation of this screening tool in a number of other trauma centers with collaborators in Seattle and at Duke. And want to have an eye to that, the considerations and what's of value in those places, as well as kind of considerations around, the implementation itself and measurement there. And if you might have thoughts even around trying to get to patient outcomes with it eventually, which has been a real challenge with this one, given that period of observation and how often you're going to see the things in which providers are going to be really interested, right? Like addiction and overdose and things like that.
Another simple question for you to answer, right?
Right.
Yeah, I'm not. First, I would lob the question back to you as you think about Duke and UW and folks. I mean, what kind of formative work are you doing to see, like, what are the similarities and differences between these contexts, and how are you? This panel, I think, represented, again, great example of user-centered design stuff and sort of stakeholder engagement. What sort of processes are you using within STOMP project to do that?
Right. So initial steps we're taking now in planning for an R01 submission is we've identified contacts at places where we have, a trauma director, and also with someone with health services, research, implementation, science expertise to kind of gather initially and talk about some things by way of, potential, specific concerns in their settings, what's happening by way of, say, screening now, what's available by way of resources. So, some work that'll need to be done that I think would be important at the front end to set things up later. But yeah, any other advice kind of on that front would be helpful too, just by way of,
I think, two themes that I, kind of mentioned earlier that seem like they're really salient for, helping to figure out your path forward. One is to define outcomes that are important to whoever the key players are. Well, actually, let me reverse my thoughts. So first of all, who's taking ownership for these pieces? So you mentioned, mental health, anxiety, screening for that, and that maybe trauma surgeons aren't so big on that. So you have to figure out who are the people, who are the first people, who would have contact with these patients and have an opportunity or a missed opportunity for doing this level of screening. And then of course you have to figure out the referrals and how that's going to work in terms of the follow-up of that. So I think, step one is finding where those receptive ownership points are. And then step two, okay, identifying what are outcomes that are really important to those players. And then you mentioned the fact that, you're trying to prevent incidents that don't occur very often, and it takes time. And so those are, kind of far distal outcomes, which would rely and be a function very much of your ability to sustain this over a sufficient period of time, plus taking into account all of the other secular stuff that hits and impacts that, that causal pathway. So the extent to which you can push those measures closer, to be more proximal, and more directly on that causal pathway, taking into account things you can actually influence and control and measure, the better. And then if you can, identify kind of multiple outcomes that are important to the multiple key stakeholders, would seem to be important. And I think this applies to, anyone, any work. And, I'm an embedded researcher within the VA Health Administration, and we're being pushed more and more and more on this kind of value proposition, this multi-level outcomes. And, lots of people have been asking about economic analyses and how to cost, implementation, let alone components of implementation. I would say that, traditionally as health services researcher, we have had a lot of emphasis on cost effectiveness analyses. So it's kind of like life years saved, dollars per life year or per quality, life year per quality, which are very abstract concepts. And what I'm finding in this space and in my work is that we're being pushed much more toward more practical, like what is the actual cost outlay? What is the ROI? I keep mentioning ROI, but that is a really important metric for us to get our arms around and to learn to speak that language. And I bring that up because that is, part of kind of this whole suite of outcomes that are important to identify. And again, the influential, kind of owners and decision makers for the work that we do.
Excellent. So
Great, thanks so much.
Yeah, thank you.
That gets back to a study that he presented. I just want to highlight, so you brought it up on your slides, the model for improvement, which the Institute for Healthcare Improvement is, all about that as kind of a central model. I personally associate that model with, quality improvement without really a great understanding of where that came from, but it sounds like you really know the history of that. And I'm bringing this up because there's increasing interest of, kind of the intersection between quality improvement and implementation science. And I think that, this is related to strategies, which is our topic for today, because when we talk about kind of loops of quality improvement, there are a lot of micro strategies and techniques that are happening in that, makes it all more difficult, I guess, for us to, be able to track as implementation scientists who really want to understand what's the impact of each of the components of our strategies.
So I'd like to see if we have any questions from Menti.
Yes, so we have several, and so continue in the couple of minutes we have left to upvote or add. But building on what Laura just said, I was wondering, there's one for Christie and Edmond, wondering if you were able yet to identify any specific cost savings in your work or if you plan to do so.
That is one of the analyses that we're planning with the current grant, is to look at the cost savings. So that's a terrific. We've done some back of the envelope where we've multiplied, the intervention, for instance, for the blood pressure intervention takes 3 minutes of MA time. So we've sort of done back of the envelope to save, like, per encounter, how much time does that cost, or what does that cost? But we're planning to formally look at that over time. So that's a great question, and that's something that we're working on.
And I would say in future work, we have a multi-site trial grant submission in which in the original submission, we were comparing two implementation strategies specifically for our tailoring component. The way we do it currently is very sort of expert driven and intensive. And we were going to compare that to a checklist-based more streamlined tailoring piece, and comparing the cost effectiveness of the two. In our resubmission, we're considering whether to do individual audit and feedback compared to group audit and feedback, partly for the cost savings.
Thank you. It's good to know that that's something you aim to do in the future. And now I see a question that's aimed towards Andrew and Randy. So can you talk about, are there best practices in measuring the fidelity of implementation strategies? This could be for anyone, but it's directed on Menti towards you two.
Well, I'll tell you what we're doing, which I think emerging best practice is exactly that kind of, I don't know if there's a name for it yet. I call it the matrix approach, which is taking what you're doing, laying it out in terms of ERIC discrete strategies, and then overlaying the Proctor framework, the actor, action, target, temporality, and dose framework. I think what's useful there is it gets to kind of the fundamental elements of engagement. So you're saying, well, we're going to have a facilitator is going to try to work with X number of clinics, and we're going to try to engage Y number of clinical staff from each clinic. We're going to have a meeting on such and such a date. It's going to last for an hour, and then you can just easily track attendance at these scheduled implementation activities to get a very concrete sense of what you intended to do, to what extent it was actually taken up by the people that you're trying to influence. I know from being a part of studies that you often go in saying, like, well, we're going to do a teleconference and we're inviting 100 people, and only 12 people show up, and you don't report the fact that really the level of engagement was much lower than you had hoped for. So I think just being really transparent and upfront about laying out prospectively what you're trying to do in terms of, like, we scheduled this meeting, we want these people to attend, and then just take attendance. So you showed up, and that's about as good as I can come up with right now for a very real and concrete measure of fidelity to proposed implementation strategies versus what's actually taken up by the action targets, if you use the terminology that's part of that Proctor and Powell specification guidance.
Yeah, and I would just emphasize, like, I like that approach, Andrew, in the sense that, again, I think a lot of our implementation strategies are much more dynamic and adaptive than we like to admit, and we sweep a lot of that variation under the rug. And so that's what the last slides on tracking implementation strategies that I kind of didn't get to. That's what we've been trying to tackle, is sort of how can we actually have methods that are pragmatic but allow us to collect what's actually happening, so we understand how we got from point A to point B. The other thing, I put a methods article in the chat, but the other thing I would emphasize is that, which I think you just hit nicely, Andrew, is the fact that we often don't, we might do a better job of capturing sort of the structural elements of some of our implementation strategies, but not so much like quality of delivery. So for instance, like a strategy that's as broad as implementation facilitation, there's a lot of factors related to sort of quality of the facilitator, what they're actually doing, and how do we capture that complexity. I think we got to get a lot better on that, as well as the sort of the receptiveness or receipt of those types of strategies. So probably thinking about fidelity as multifaceted as we do in sort of the treatment intervention literature is probably a good approach.
Well, I want to thank everyone for this panel. It really helped consolidate the learning, I think, and see the additional questions it prompts, but also how it drives the work forward into change in practice. So it's now time for a lunch break, and we will be reconvening in the afternoon on the separate links that you have received for either group A, B, or C. And then we will not have a general session for the rest of the day, but we will email you the meeting links for tomorrow when we start up again in the morning. And if you have any questions, please use the chat function, and then check your personal Zoom link for the afternoon breakouts. So thanks very much.